Hello, everyone. My name is Kim Allison. I'm a professor of pathology and I run the breast pathology team at Stanford Hospital. And today I'm going to be talking about optimizing the identification of HER2-low breast cancer. We're going to be talking about HER2 in breast cancer in particular. Um, and I wanted to start with this slide showing the evolution of the HER2 ASCO CAP guidelines, just to tell the story from the beginning a little bit about how our HER2 testing was really initially developed and validated to identify those HER2 addicted or HER2 overexpressed amplified cancers that might be candidates for trastuzumab from the rest. And all of our energy and focus was on identifying those and distinguishing them from non-amplified, non-overexpressed cases. It was really in 2007 that it was recognized that there might be some issues with local lab testing this new predictive marker, and guidelines were created in joint with ASCO and CAP around setting standards. And really, for the first time, we're looking at things like tissue ischemic time and making sure these tests that are predictive are validated well. Um, we've had two focused updates since that initial, really more about fine-tuning, um, resolving equivocal results, fine-tuning definitions for ISH categories. And then in 2023, we had the affirmative update to address what has evolved and is going to be the topic of most of my talk, to address HER2-low and TDXD's indication for HER2 testing in cancers that are not overexpressed or amplified, and addressing needs to potentially change reporting and best practices to identify those cases. So I'll talk a bit about that, identifying those in pathology. Again, the goal before 2023 was really to accurately identify overexpressed amplified samples. We have the IHC testing algorithm here because IHC is usually used as our first screen for HER2. And the ones that are 3+, really strong membranous staining, have high levels of HER2 protein on the cell surface. Those are clear-cut positives. No reflex testing is needed, although some labs do dual test and you'll get an ISH in situ hybridization result as well. But the 2+ category, which is less intense circumferential membranous staining, those get reflexed to ISH testing to confirm whether it's amplified or not. And then anything below 2+, and again, these are subtle differences that require pathologist training and proficiency testing to be able to distinguish. It's not an ER stain where you're looking at percent positive cells. This is a subtle differences in intensity that pathologists really get trained to interpret in a reproducible way. So anything less than 2+ staining, difference between moderate to non-circumferential staining in a 1+, and then the IHC 0 category you can see in this figure includes 2 staining patterns, either no staining or less than 10% of the tumor cells having faint, imperceptible, incomplete staining. So very subtle. They're lumped together in this IHC negative category, which will become relevant. And as a pathologist, I know I'm really speaking to a medical oncology audience here, but I always like to emphasize to pathology audience the tips on IHC interpretation, that really the intensity of the staining is key, but also using fresh cut slides, you can have a decrease in intensity of the stain. If you're using old archived material that is not fresh cut off of a tissue block, we've got some unusual staining patterns that pathologists need to be aware of that should be called equivocal. And then, issues like crush artifact that make it really hard to interpret membranous staining because the membrane's been disrupted. The one thing I would really like to emphasize, though, for medical oncology, because sometimes you'll be the first to notice, is concordance with histology. So if you have a grade 1 cancer or a favorable histologic type in breast cancer, so like a grade 1 invasive lobular cancer, for example, it's very, very unusual to be HER2 3+ positive. That is worth double checking. That is worth talking to your pathology group about, when you see that level of discordance. It's pretty easy to pick these up in the low grade 1 cancers, or like an adenoid cystic, one of the mucinous carcinoma. Really be wary if those are 3+ positive and have that double checked. HER2-ish testing I won't spend a lot of time on. Most commonly that's done by FISH, or fluorescence in situ hybridization testing. That's not available at all labs. It takes several days to have a turnaround time on that. And many labs will send that testing out to reference labs. DISH testing is dual in situ hybridization testing that uses chromogenic probes, so you can see them under the light microscope. So some pathology groups may be using that. We're using that at Stanford now in addition to FISH. We have both online. And the pathologists themselves scores those rather than in the lab in the fluorescence scope room. But there still are issues in ISH testing and a little bit of gray zones, including low amplified cases. We see sometimes cases with just above threshold results that can be discordant with IHC results, and issues post-treatment with borderline results or heterogeneity. Dr. Love, question.
So, a couple questions. So, one thing is just curious. I've seen a bunch of papers looking at AI, artificial intelligence, to try to read pathology and imaging. How about HER2 testing? Any efforts there? Can you put together an AI program to do it?
Yeah, great question. So there are digital image analysis programs and packages that can be used to help with your HER2 interpretation, and many labs do use them. They're an aid, right? You still have to know what you're looking at and have to make sure that tool is calibrated properly, because it can be calibrated in a way that it might call too many cases positive, um, because it's a subtle difference. But yes, there are tools out there already. AI driven tools aren't, I think, mainstream yet. There are digital image analysis packages that are not AI driven, but probably are coming down the pipe. And you're right, that may help a lot with these challenging tests to interpret, PD-1 included. So
Yeah, I can
yes.
never tell the difference between like AI and some other computer way of doing things. But I mean, the bottom line is, are we going to have a day where you send a specimen out and you get back really reliable, national, verified IHC? But anyhow, I guess that's not here now.
Yeah.
Another thing wanted to just sort of check with you, and again, I know we're talking about breast and HER2-low, but again, with this pan-tumor approval, I keep hearing people outside of breast, again, GU, all these other people going, oh, they had, they were HER2-low and they benefited because they were 2 plus, and I don't see any FISH testing. So am I correct in saying that if you have somebody who has a HER2 assay that shows 2 plus, in breast cancer world, they could be HER2 positive if they're FISH positive, but yet if you don't do the FISH, you can't really call them HER2-low. Am I right? Because I keep telling them that. Is that correct?
That's my understanding for breast. Again, I don't know every other organ system well enough to say for sure you don't need it, but I would imagine you'd want to distinguish amplified
Yeah,
from non.
yeah, yeah. Well, I'm
Response will
sure
be
that's
different.
coming. I mean, at
I
this
guess,
point, I don't hear very much about HER2-low outside of breast right now, but I imagine that maybe it's coming with more research. One other thing I just wanted to ask you about, you kind of mentioned a little bit, but it's something I've been really curious about, which is lobular cancer. I kind of like we were approached by an advocacy group for lobular cancer. It's like we don't see any stuff on our thing, and like everybody tells us we just have ER positive, HER2 negative disease. Do you think that lobular is so easy a diagnosis that these people get labeled in the beginning? Everybody always knows it.
I mean, I think there are subtleties to a lobular cancer diagnosis, and there is more of a spectrum than, just they're all the same bin. There are variants of lobular There are lobulars that, can be rapidly proliferating. There are pleomorphic forms of lobular that can be HER2 positive. So we do want to always test both ER and HER2. And they're a spectrum. The vast majority of the low grade, grade 1 invasive lobulars should be ER positive, HER2 negative. And that is a nice double check to know that biology matches. But
Have you seen any hypotheses about why you see this different clinical behavior with lobular? I hear about cadherin or whatever. Anything that you've seen that maybe explains why they're clinically different, even though they look like ER positive or 2 negative?
yeah, from my perspective, lobular, because it's lost cell adhesion capabilities, it's lost E-cadherin, and that whole complex is dysfunctional. It's able to spread in a unique way in single cell, kind of like water through the stream, through the rocks in the stream, in an easier way. And so it's subtle. It tends to more often in the breast be multifocal, um, and then to have subtle forms of, being more than met the eye on imaging, because it barely disturbs the tissue. So it's very hard to pick up some cases of invasive lobular early. Um, and certainly metastatic spread has the same issue, is it can be surreptitious until it's, filled an organ or, lined an organ.
I mean, there's a lot of people who get lobular. I'm surprised you don't see more targeted trials. I mean, something. I don't see much on lobular at all.
I mean, the good news is it's usually very ER driven. So our hormone therapies work really well in lobulars. I mean, in that way, it's similar to a lower grade invasive ductal that's very ER driven, and they're very similar molecularly, except for the loss of that cell adhesion molecule. So um, they're not too dissimilar. And you're right. I mean, it's a separate histologic type, and it has lost cell adhesion capabilities. And there's nothing targeting that specific um, loss of adhesion, but it is a very ER-driven process. So that is the good news.
All right, let's keep going here.
Okay. All right. So moving on to what we're going to be talking about, looking at lower levels of HER2 expression and potential benefit from HER2 targeted antibody drug conjugates. So this was a real shift in our thinking on HER2 testing, because again, designed for overexpressed amplified detection. So I'm sure many of you are familiar with Destiny Breast 04 and the trastuzumab deruxtecan trial using TDXD in the metastatic setting for hormone receptor positive and some hormone receptor negative HER2 non-amplified, non-overexpressed cancers. So they included in this trial IHC 1 plus or 2 plus FISH negative. They used the term HER2-low to describe this, I think, sort of for practical purposes, right? Because saying IHC 1 plus or 2 plus FISH negative is a bit of a mouthful. But so lower levels of IHC expression were included, and of course had very nice efficacy in progression-free and overall survival. There was some potential toxicity with fatal interstitial lung disease occurring in less than 1% in this trial. This was big news. It was practice changing, and FDA approved it pretty quickly. And they also approved an expansion of the indications for our 4B5 HER2 IHC assay. So one of the assays that was most commonly used for HER2 testing to identify our overexpressed cases. Now the FDA approved that the same test can be used to identify these HER2 lower expressors, but a new indication. But I think it is, good to look at carefully what was included and not included in this trial. So IHC 0 cases were not included in Breast 04, the Destiny Breast 04 trial. And also to note that they didn't use a new scoring system. They used the ASCO CAP FDA approved scoring system with IHC 0 or versus 1 plus or 2 plus. So because everyone had benefit in the trial and they didn't include the IHC zeros, we don't really have a new predictive threshold between 0 and 1 plus, but we do have a clinically relevant threshold now because of clinical trial eligibility inclusion criteria. And we think about that, is it a predictive threshold when we look at changing guidelines? We also were interested in knowing, did the specific level of IHC expression, 1 plus versus 2 plus, make a difference? Because one might expect that the more HER2 present on the cell, the more response you might see. And it didn't appear to look like that was true in Destiny Breast 04. This is the waterfall plot, and you can see the different colors of blue for the IHC 1 versus 2 plus. So that was interesting to note, that maybe just any amount of protein is all that's needed for that ADC to be effective. And it really changed our scoring implications, our paradigm here. So we've got on the top our HER2 3 plus or 2 plus ish positive. Those test results are predictive of benefit for a whole host of HER2 targeted therapies. For 2 plus ish negative and 1 plus, now these patients are eligible for TDXD in the metastatic setting. Again, not clear if it's predictive of response, and separates out the zeros in a way that is predictive. So basically, the zeros were unknown if they respond to TDXD at that time. And at that time, with our 2023 affirmative HER2 guidelines update, this was really our question. Should we be changing? Should we change terminology in our reporting from negative, equivocal, and positive? Should we add HER2-Low? Is that a real separate entity? And because it wasn't clear yet that this was a new predictive category, we didn't feel like there was enough evidence to change reporting terminology yet. And there were other issues. So an equivocal IHC 2 plus, you can't report that as HER2-Low unless you get the ISH result back. So that was sort of a practical consideration. And then again, we really didn't need to change our scoring criteria because they used the same scoring criteria that were originally in the ASCO CAP guidelines. So this DB4 results did create a quandary for pathologists, and it felt like we needed to address this with some best practices. But now we've got this clinically relevant, although untested threshold, IHC 0 versus 1 plus. There's data looking at reproducibility in this area, that I think can improve with training. But I think importantly, it wasn't really what this assay was developed to or standardized to discriminate between. And there are a lot of concerns that IHC 0 is really just a limited of detection or a fixation artifact issue, and that there really is no IHC 0, no protein present result in reality. That is a false negative result when you get an IHC 0. And we can't really currently prove that in any other way. We don't have a reflex, more sensitive assay like we do in the 2 plus setting when we want to know, is it an amplified result or not? We can send for an additional test that will give us the final answer. And we really don't have that in this setting. And it's also unclear what to standardize against. We don't have good controls that will tell us your threshold for 0 versus 1 plus is calibrated well. When we were thinking about terminology changes and looking at guidelines, the ASCO rapid update and the NCCN guidelines are really defining the 1 plus and 2 plus ish negative, not using terminology like HER2-Low or ultra-low, as we'll talk about next. And so we felt like that was the right thing to emphasize, that the information is going to be there in your pathology report. We need to be including the score, the IHC 0 or the 1 plus result. You've got the information you need in that, and you can decide whether you're going to be treating or not. So awareness was a big issue, and part of our interest in getting this out there to pathologists to be aware that this new threshold exists. They should be scoring carefully, and that There are a number of best practices that pathologists can use to help discriminate this now relevant 1 plus versus 0 threshold. Looking at high power when you're trying to discriminate, looking for any areas that might, influence the 10% or more with some partial membranous staining to call it a 1 plus. Considering a second pathologist review when results are close to that threshold. And that's also what the FDA-approved packet insert tells you to do for the antibody kit. We also recommended using controls with a range of protein expression that includes the low end of the spectrum. I think initially, in pre-TDXD, we were using controls that were 3 plus positive and negative, because that's all you really needed to discriminate between. But just like we want to pick up ER lower cancers, we want to pick up this lower threshold now. And so at Stanford, we use a TMA on our slide that has multiple different samples that have a range of controls. But again, the 3 plus is the most validated control because you've got FISH testing behind it, and you don't really know the 0 versus 1 plus, what that needed to be calibrated to. There's no validated control to test that against. And then thinking about pre-analytic conditions, especially in the metastatic sites. So letting your pathology group know, I'm testing, I'm sending a metastatic site in, please, I want to have it tested for breast cancer biomarkers, and we really want to pay attention to the pre-analytics, not have it put in something other than formalin, for example, or not have it have a longer ischemic time. Usually small biopsy samples have a very short ischemic time and go right into formalin, and that's not a problem. And then we had some best practices for medical oncologists. Now, because DB04 considered IHC results on either a metastatic site, or if that wasn't available, they could use a prior concurrent primary sample. We said, look, we recognize that these samples, this is not a super reproducible threshold, and your samples that are IHC 0 may be a fixation artifact sometimes, maybe a false negative. So if you've got multiple samples over time, anything that's non-zero, you can use as a result that could make a patient the candidate for TDXD. This diagram just shows how variable it can be from the primary to the relapse in terms of the HER2-low. Much more shift there from low to null or null to low than would be expected if this was a special biologic category like HER2 positive is, where there's much less of a shift. All right, and then I think the next question we really have as we start to talk about ultra low and lowering that threshold even more is, do we really even need HER2 testing for TDXD eligibility, at least in breast cancer? I think that's a very relevant current question. And the DAISY trial, was a phase 2 smaller trial, but it really brought that question to the forefront, because in this trial, they included IHC 0 cancers, and they seemed to have a similar response to the HER2-low cancers. Possible explanations being maybe the IHC 0 is false negative, or it's just below limit of detection, or possibly cancers are heterogeneous and there was some bystander effect, that those were false negative because there were other areas that were positive that weren't tested. So I think that was provocative. And then I'd also bring up that there are other ADCs that do not use a biomarker to link to make a patient a candidate for this therapy. In the triple negative setting, sacituzumab govitecan is an ADC to the TROP2 antibody. We do not test for TROP2, and that's okay. So we may not need to test with some of these ADCs for their linker. All right, so shifting to Destiny Breast 06, these are the late-breaking results. The inclusion criteria that were key is that they were metastatic, had HER2-low, so again, including mostly HER2-low breast cancers, or they expanded it to include a subset of the IHC0 group, so any staining. So the cases that are less than 10% with any staining were able to be included in this trial. Again, we still don't know. We didn't. I was disappointed they didn't include all the zeros, because then we would have some answer if there was a new threshold to look at, or if potentially everybody benefits and we can stop excluding people from this great new therapy. So, those were the key inclusion criteria. And again, we won't know a new threshold because it wasn't inclusive of all zeros. The study design, again, hormone receptor positive only this time. And really one of the primary goals of this trial was, can we give this earlier in the metastatic treatment paradigm? So these are chemotherapy naive metastatic hormone receptor positive breast cancers. They may have been treated with hormone therapy and other targeted therapies, but not chemotherapy. So moving T-DXd to earlier in the metastatic treatment for these patients was really the primary goal. HER2-low was the majority of patients included, but there were some ultra-lows, 153 of them total. And so it was T-DXd versus physician's choice. Key eligibility criteria, I won't go through all of these, but just to emphasize one point that is different from DB06, they had to have used a sample taken in the metastatic setting to send to the central lab for the testing to see if it was HER2-low or ultra-low. All right, so what is ultra-low? I thought it would be good to show an example here. So on the right, here's a case I think we can all agree there's no staining, and what the staining looks like is brown. So we've got blue nuclei in an IHC stained slide on all of these three images. On the left, we have some faint brown staining, and just to show you how subtle that is, that's great. And it depends on your population you're testing. So if it's more than 10% of all of the cells in your sample that are invasive metastatic cancer, with this degree of staining, you can call it 1 plus on the left, and you would call it 0 on the right. And in the middle, still in the 0 category, is a case that has very faint partial membrane staining, but it's less than 10% of the overall population. It's very hard to take an image of that, because we're looking at a whole slide and a whole population of cells and trying to estimate, is it more than 10% or less? But that's essentially, that middle category is what is being called HER2 ultra-low in this trial. Very subtle. And of course, the results were nice. So this is in the HER2-low primary endpoint, looking at progression-free survival with a difference of 5 months, so meaningful clinical improvement, and a nice p-value and hazard ratio. So it works. It works earlier in treatment. And then when they looked at the ultra-low subset, so again, this is not what they were powered to do initially. So this does not have p-values. And you can see the 95% confidence interval crosses 1, but it looks similar in the ultra-low to the low group. And another, the waterfall plot and looking at more detailed data, looking at similar looking responses in the ultra-low and the low. Again, lowering that threshold, potentially, HER2 testing doesn't matter in this setting. It's looking like that might be the case. Again, numbers low in the ultra-low category, though. So potential implications here, we've gone from HER2-low versus IHC0. We're trying to split that IHC0 category now into an ultra-low versus no staining category, and then expanding the eligibility for T-DXd. But really, the primary point of this trial was to move T-DXd to an earlier line of treatment in HER2-low metastatic breast cancer. And that's the big difference from Destiny Breast 04. It does look like it may expand that indication, though, but it hasn't been FDA approved yet. It's not published yet. But if it all looks the same in the end and is approved, potential eligibility is now expanded. Again, we don't know with the zeros if they respond, because they were excluded. And I think there is a trial, maybe DB15, that may answer that question finally once and for all. So now the problem is, if this is relevant and we have the opportunity to treat ultra-low expressors in the metastatic setting, we need to know about them. We can still use the same scoring system. The guidelines really don't need to change in their core because we had this scoring already embedded. It's not a new scoring system or a new entity. So IHC0 cases, we have two categories. They can either be no staining or this ultra-low staining. What we really need is to report the details of what's in this box so that we can identify who's eligible now, potentially. And unfortunately, guidelines take a long time to update. They require a panel reforming, multiple meetings, new evidence to support changing reporting and thresholds. There are ways to do rapid updates that are more abbreviated and kind of give commentary. In College of American Pathologists, that's even more challenging because we have standardized reporting templates that need to change, and those can take a long time to update and get out to all of the systems. And the one that we use currently does not separate the zero category into two identifiable scores. So that I think we do need to focus on, and we need to really have more ways to rapidly update and have clinical trials work with pathology reporting organizations early on so that we can be ready for things when they come out. So the way I see it is there's a couple of options. I think option one is where we need to go in terms of reporting. We would need to take our standard negative category, which we currently report as score 0 or 1 plus, and just add that level of detail where we say no membrane staining detected or incomplete membrane staining in less than 10%. I don't think we need to use terminology like low and ultra low. And that terminology may go away if it ends up being not relevant. But this is one way that we can get that information in a standardized way into our reports, is by changing our templates to add this level of detail. There are other concepts that we could apply, like, well, if there's any staining, why don't we just lump ultra low and low together into the 1 plus category? It was probably arbitrarily originally created that there was this 10% threshold for staining without any real evidence behind it. However, again, to change a guideline and our figures in it and our scoring would take years. And so I think that one's less likely to come to fruition than adding the detail. For now, option 3, pathologists today and oncologists can ask for an additional reporting comment describing the staining in the IHC0 cases as a more immediate way to address this, but it's very hard to make that standardized until the standardized reporting templates can be pushed out to the system. And last, just to emphasize the problem of controls, and I really implore clinical trials to think about this, that if we need to implement this testing with this subtle threshold, we need to be able to have controls, not just the ones to validate your initial test, but the ones that you can use on a daily basis to make sure your assay each day, each run, each sample is detecting this subtle, small amount of protein expression that we really want to have some controls that are validated in a clinical trial setting or other to calibrate against. And that this is really challenging for us. And last, I really there's evidence out there, and I believe that IHC0 does not necessarily mean there's no targetable HER2 protein, that it really only means below limit of detection. Aqua-IF is one method that's been looked at to um, do a deeper dive with a more sensitive assay using mass spec. This is David Rim's lab at Yale, looking at IHC0 cases using this more sensitive method. 2/3 of them have some detectable levels of protein expression. So really, I think these IHC0 cases, it's very rare to have a case that has truly is null for HER2. And I'm hopeful that maybe eventually we won't need HER2 testing for this indication in particular. We will still need HER2 testing for the whole panel of, to identify the amplified overexpressed. And that's what our test is good at doing, and distinguishing from the rest. But for TDXD eligibility in the metastatic setting, we may not need it. I love this figure where HER2 testing, evolution over time may go back to where it started from, if that's the case, where we were distinguishing positive from negative, and then moving to include and identify low, then ultra low, and get really detailed. Really, again, not what the assay was designed for, but we're doing our best based on clinical trial eligibility issues to maybe it won't matter in the end and it will go back to positive versus negative. Again, clinical trials, we really need to make sure that they are testing predictive thresholds if we want to create new thresholds for biomarkers. Prediction's important, and that's what we validate in pathology against. And then if it is relevant, we may need things like image analysis or innovation in quantitative testing, measurement, and scoring at the low end of expression if we really do need to go there and identify the null from any HER2 expression and standards, again, to measure against. That's all I've got for you today. Questions?
Yep, I've got a few of them. So one thing is, even if it turns out that everybody with breast cancer, and who knows, maybe this is going to apply to all the other tumors. I mean, I don't see any reason why HER2-low wouldn't work outside of breast, but of course that's going to have to be tested, and I'm not sure that it has. But even if we do find that there are almost no people who you can't give TDXD to, do you think that just the predictive value would be useful? So how much of a difference is there between 3+ amplified and ultra low in terms of actually benefit? I mean, maybe that's a little outside your thing, but do you,
Yeah,
you
I
know,
mean, there.
that could make a big, if it was like the difference between a 20% and 60% response rate, that would
Yeah.
be very helpful.
So I think it is predictive of a difference in response. So the HER2 addicted, overexpressed, amplified, they respond a lot, better than the ones that are not. But I think the real question is, so you'll need HER2 testing in that sense to identify the high level. But I don't think we ideally want to be applying this test that's good at that distinction to fine tuning, very low ends of the spectrum, low level expression from no expression. I think that might unnecessarily exclude patients from therapy in a false
Well,
way.
I mean, I don't know about the type of testing, but exactly, but all I'm saying is that even if you end up using TDXD in most or all these patients, it still would be helpful to be able to predict how likely it is that they're going to benefit. But maybe not. Maybe the HER2-low benefits so much practically doesn't really matter. I don't know. But I think it would be something oncologists, doctors taking care of these patients would value. Because the thing about TDXD, it's all well and good to say, oh, you have this trial and it showed greater benefit, but you also have interstitial lung disease hanging in there. And that's a clinical issue, doesn't relate to pathology, but clinically, you have to weigh that. You're going to introduce some level of risk of ILD. And if the response rate is, 15% versus 65%, you may view that differently. You have a patient who already has lung disease, you're really nervous. You see what I'm saying? That the clinical
Yes.
picture could end up, sort of changing the way you approach it.